We're going to be talking about language, about visuospatial abilities, and about the brain's emotional and social functioning. And when we think about language, immediately we think of the left hemisphere. But as you'll see today, the left hemisphere is obviously not the only part of the brain involved in language, but the right hemisphere has some involvement as well. And we're going to be looking at visuospatial abilities, which one tends to mostly associate with the right hemisphere, and then your emotional and social abilities, which one tends to associate with the limbic system, and then also, to an extent, the frontal lobes. Okay. So let's start by talking about the language and the brain. And we're going to be talking about two main, I think one of the main things when we think about language is aphasia. But we're also going to be talking about dysarthria and the difference between the two. So now, aphasia, in the definition according to Darby and Walsh, is an acquired impairment in the reception, manipulation, or expression of the symbolic content of language due to brain damage. So let's just break that down a little bit. By acquired impairment, what that really means, and this is important for us, it didn't exist before. So a child is born with a language difficulty. You can't later say they have aphasia. So aphasia is acquired impairment. In the reception, which means listening and understanding, manipulation, which refers to the manipulation of language, for example, through poetry, puns, and so on. Expression, speech. Symbolic content, in the forms of letters, symbols, numbers, of language due to brain damage. And the types of brain damage that we often think about when someone has aphasia is traumatic brain injury or stroke. Okay. Just so that you remember the terms, aphasia, the A of aphasia means not. So when you think about aphasia, it means there is no speech. Okay. Dysphasia means abnormal, difficult, or impaired. So if we talk about dysphasia, we're talking about impaired speech. But you'll see later, aphasia and dysphasia are sometimes used interchangeably. So some people will refer to aphasia when they actually mean dysphasia. And one just needs to understand that they are used interchangeably. There we go. So aphasia is often used instead of dysphasia. Okay. Now, there are many different types of aphasias. There are many different types of aphasias. The one that I think or the two that we're most familiar with is Broca's aphasia and Wernicke's aphasia. So let's look at Broca's aphasia first. And what one needs to understand about Broca's aphasia is that it's a motor aphasia. If you think about where Broca's area is, and you think about where the primary motor cortex is, you can see that Broca's aphasia is in this premotor cortex area. Now, different diagrams will show Broca's area in slightly different regions, but it is always in the region of the premotor or motor cortex. And what that illustrates for us, it's a motor disorder. It's possible to have a complete loss of speech, otherwise some people just struggle to speak. Vocabulary is often affected. In other words, if you're doing like the vocabulary test of one of the Visuospatial tests, and somebody's having difficulty explaining what words mean, they might know what the words mean, but they might have difficulty explaining the meanings, possibly due to aphasia. Agrammatism is also a type of aphasia, and that is the loss of the use of grammar, where people will speak in sentences, but they're not full sentences. They leave out certain parts. It almost sounds like a bit of a staccato speech. And agraphia is difficulty with writing. So somebody might actually be able to speak, but they might not be able to write. And that's one of the reasons we always ask our patients to write something. Sometimes they've already written something by the time you see them, because they've maybe filled in their name and address on the forms. But if you haven't seen that, then it is useful just to ask them to write something. Now, Wernicke's aphasia is when there's damage in this area here, the superior temporal lobe. You know that the temporal lobe is divided into three main sections. You have the superior gyrus, the inferior gyrus, and the gyrus in the middle. So Wernicke's area is the area affected in the superior gyrus, or damage to the area of the superior temporal gyrus. And it is a sensory aphasia, okay? Because when we hear, whether it's music or language, when we hear something, the primary auditory area is Wernicke's area. That information gets processed there first. Then it gets processed further, and it goes around, it gets processed in the areas around Wernicke's area. Okay, and we will get to that now. Now, Wernicke's aphasia is associated with a loss of association between words and their meaning because they cannot hear what they are saying. Loss of association between words and their meaning because they cannot hear that what they are saying does not make sense. So this is often where you get a person who is speaking, they're perfectly capable of using words and speaking, but they're talking nonsense. It's a jumble of words, like a word salad. But they don't realize that what they're saying isn't making sense because they can't, what they're hearing is not, they can't hear or understand what they're saying. You get an auditory receptive aphasia and a visual receptive aphasia. Your auditory receptive aphasia is what one normally associates with aphasia. It's the difficulty understanding what is said to them. Damage would be in the superior temporal convolution, as I mentioned. You also get a visual reception aphasia, which is difficulty understanding what is written, and the damage there is normally in the parieto-temporal region. Alexia is word blindness. A, remembering, means not. Lexia means reading. So if you cannot read, we call it alexia. They cannot see the words. You might recognize individual letters and say this is an A, this is a D, but you can't put them together and recognize a word. Dyslexia, we're going to talk about soon, refers to developmental reading difficulty. And there is also a phenomenon called alexia without agraphia. Alexia without agraphia. The person cannot read, alexia, without agraphia. Agraphia means you cannot write. So alexia without agraphia means that they cannot read, but they can write. So they cannot read, but they don't have this problem of agraphia. Okay. They cannot read, but they can write. All right. Now, you also get global or mixed aphasias, where there's both a motor and a sensory aphasia. These cases are severe with extensive lesions, and you can understand that because, Broca's area is here, Wernicke's area is there. For somebody to have damage in both areas, there's not much of a chance that they're only going to have damage there and only damage there. What are the chances? What would lead to somebody having only damage in those areas? So for both areas to be damaged, it probably means that there's an extensive damage around there affecting both areas. There are different terms for nominal aphasia. Sometimes it's referred to as amnestic aphasia, sometimes amnesic aphasia, sometimes anomic aphasia, or nominal aphasia. But what all of those terms mean is that the person has difficulty with naming. They have naming difficulties. So they have difficulty thinking of the names of people, but I think we must be careful not to, a lot of these things are fairly, a lot of us struggle with remembering names of people. But what I'm talking about here is a pathological disability or difficulty with remembering names of people. And difficulty identifying objects by their proper names. And how we test this is that you show a person an object, or you show them pictures of objects, like the Boston naming test, and you ask them, what is this, what is that, what is that? And there should be objects that they're familiar with, and they should be able to know the name easily. And if they can't think of the name, they may be having this naming difficulty. A different type of nominal aphasia is circumlocution, which is an indirect way of talking, using an unnecessary amount of words to describe something instead of just saying the word that you are describing. So what you normally find with this person, they're very talkative, and instead of just getting to the point and saying what they need to say, they'll talk around it and around it. They just can't get to the point. So I found this little illustration I thought was quite fun. So instead of a box, the person might call it a cubic containment system. Or this might be a misapplication elimination device. This is a vermin de-infestation apparatus. This is a follicle redistribution mechanism. And this is a horizontal tranquility terminal. Okay. So now people with circumlocution execution won't necessarily go to those extremes, but you do find that they talk around the point. Now, there's a different type of aphasia called conduction aphasia, and the lesions there are along the arcade fasciculus. Now, I don't know if you remember the arcade fasciculus. I think most of us, when we learned about Broca's aphasia and Wernicke's aphasia, we would have learned about the arcade fasciculus. It's a band of white matter fibers. Here it is. This is a DTI scan. Here's your band colored in red of white matter fibers that illustrates how these pathways go from Wernicke's area to Broca's area. Here's just quite an old picture of part of the brain that's been cut away, and you can see these fibers running there. That's an arcade fasciculus. Now, if a person has damage along there, your Wernicke's area is intact, your Broca's area is intact. So you understand language and you can speak. However, there's an impaired ability to repeat what has been heard. So if you say, repeat after me, they're not able to do that because this pathway has been damaged from the hearing and understanding to the speaking. And how we pick that up in daily living is, for example, if a person can't pass on a telephone message because they can't repeat what they've heard. But in our assessment, in practice, you can pick this up with digit span. If they can't, because you ask them to repeat what you've just said and the digit span forwards. If they have difficulty with doing that, then you might suspect that they have this problem. And even the Ray auditory verbal learning test, you're reading them a list of words, you're asking them to remember what you've learned, but you've also asked them to repeat it. And if they're having difficulty with that, you need to ask yourself, is it because of immediate memory difficulties, or is it possibly that they're having a conduction aphasia problem? Okay. Now, transcortical motor aphasia. If you can, when one has transcortical motor aphasia, it refers to anterior lesions beyond the inner perisylvian language area. So in other words, typically just in front of Broca's area. Remember, peri means around or near. So around the sylvian, remember here's a sylvian fissure? Around the sylvian fissure and language area. So in front of Broca's area. Broca's area is about there. So referring to damage there. And that can cause motor speech difficulties, as with Broca's aphasia, but with preserved comprehension and repetition. Okay. And the person can't say spontaneously, I'm thirsty, but they can repeat, I'm thirsty. So if you go to somebody and say, are you thirsty? And they say, are you thirsty? Then you know they're actually just repeating what you're saying. Maybe they didn't actually understand what you're saying. Transcortical sensory aphasia is where there are posterior lesions near and around Wernicke's area, so around that area. People can repeat words and sentences because the arcade fasciculus is intact, but they can't understand what they mean. So they cannot understand what is being said, such as good morning, but they can repeat what is being said. So again, if you say good morning and they say good morning, you don't really know if they're now just repeating what you've said or if they're actually understanding you. So mixed transcortical aphasias, where both Broca's and Wernicke's areas are spared, but they are isolated from the rest of the brain. The language dissociation areas are damaged. Remember, we have primary association areas, and then where the areas that process the information further, your secondary association areas. So here, the primary association areas are spared, and the areas around it are damaged. So speech production is impaired, auditory comprehension is impaired, the ability to repeat spoken words is intact, because Broca's area is intact, Wernicke's area is intact, and the arcade fasciculus is intact. And interesting, people who have these difficulties, they can sing songs that are familiar with them. If you ever have somebody who has difficulties with speech, always check how they are with singing, because singing involves slightly different pathways than just ordinary speech. I know that sometimes the speech therapists also, if the person's struggling to speak, they also get them to sing because they're sometimes more capable of doing that and gives them some confidence. And it builds up the language areas. Now, as I said, it is true that the left hemisphere is mostly associated with the language, but the right hemisphere also plays a role. And the right hemisphere, believe it or not, can recognize words. but has little understanding of grammatical rules and sentence structures. Now, interestingly, verbal information sent to the right hemisphere, there is good auditory comprehension of language in the right hemisphere. And if you remember, the auditory pathways go to both hemispheres. Now, prosody is this, more than anything, when we think about language, the effect of the right hemisphere with language, we must think of prosody. It's the rhythm, stress, intonation of speech, emotional state of the speaker, the form of the utterance, example, whether it's a statement, a question, or a command, the presence of irony or sarcasm and emphasis. Those are all the aspects of language that the right hemisphere has to deal with. So if you have somebody who has right hemisphere damage, they might speak in a very monotonous voice because it's the right hemisphere that helps us pick up on the little intonations, little emphasis here and there, where, you know, there's a difference if you say, he went to school today, or he went to school today. You know, there's the same word, same sentence, different emphasis, different meaning, and that's what the right hemisphere is responsible for. Okay, let's talk about dyslexia. Remember again, in Greek, a means not, dys means abnormal, difficult, or impaired, and lexis means a word or a phrase. So dyslexia really means difficulty with reading. Now, this word, dyslexia, is often used far too casually and used to explain far too many things. But if you have somebody who has difficulty reading, as a neuropsychologist, you need to try and pull apart all the different functions of reasoning and all the different things that could be contributing towards this person not being able to read. So let's look at some of those things. You get an attentional dyslexia, where one letter is present, when one letter is present, naming is normal. But if more than one letter is present, naming is difficult. So the person can recognize letters individually in words, but he can't put it all together because he can't pay attention to the whole word, only attention to one letter at a time. That's attentional dyslexia. Then get an aspect of neglect. When the first half or last part of a word is misread, example, mother is read such as brother, where one part is neglected and the mind kind of makes up what it thinks it's supposed to be. Okay. Then you get surface dyslexia, where the reader cannot recognize words directly but needs to sound them out. Spelling is impaired but is phonetically correct. I'm sure we've often seen these kinds of patients. Surface dyslexia does not develop in languages that are totally phonetic. So you can understand that, you know, if there's a language, you get some languages that are very phonetic, then people are not going to make these mistakes. It's because they have the difficulty when the words are not phonetic and it's difficult to spell them. Then you get deep dyslexia, where the reader makes semantic errors, where he reads related words instead of words he's meant to. So he reads, what he sees is Mary instead of Christmas. He's getting confused between the semantically similar words. Verbal verbs or function words present the greatest difficulty because there are so many semantic similarities. You get phonological dyslexia. It's an inability to read non-words aloud, like blog, merg, spog. And then you get what you call letter-by-letter reading, where the reader spells words out to himself to make up the word. Okay. So, as I said, if you have anybody struggling to read, or let's say you have a referral from a teacher who says this child has dyslexia, you've got quite a job on your hands to try and tease out exactly what is it with this child that they are struggling to read. Now, dysarthria is a difficulty with speech, but for a completely different reason. This has got nothing to do with the brain itself or with the language areas of the brain. This has to do with the physical aspects of speech. The larynx, the pharynx, the tongue. And remember that the brain also controls movement, it also controls movement of the mouth. So if you have, for example, cerebellar damage, it's also likely to affect the motor aspects of, the physical motor aspects of speech. Now, applications in neuropsychological assessment, and this partly answers your question. How do you recognize if people have these difficulties? In general conversation, sometimes you can just pick up immediately if a person has a speech difficulty. How they respond to instructions. Are they understanding you? Do they misunderstand you? Is there maybe some sort of language comprehension difficulty? The vocabulary test, if they can explain the meaning of words. Token test. I don't know if you know the token test, where you give more and more instructions, they become more and more difficult. Also to understand the comprehension. Reading, getting a child to, or a person, adult, to read, to write. You get some formal writing tests, but as I said before, sometimes I just get a person to write a few sentences about themselves, just to get a nice sense of, are they spelling correctly, are they having grammatical difficulties? Reading nonsense words, you can actually make up some of your own nonsense words and just get a sense of, can they read it? In terms of naming, you get the Boston naming test, and then also in the R bands you get a picture naming sub-test, which is quite helpful. In terms of repetition, to see if somebody can repeat words, we can look at the digit span forwards, and as I said, also the Ray auditory verbal learning test. You can test for verbal fluency using the controlled oral word association test. That's where people need to make up words beginning with the letters F, A, and S. And I've probably mentioned this before. There's been a wonderful study done on the FAS in South Africa amongst English-speaking, Afrikaans-speaking, and Xhosa-speaking people to see how similar, how fair is it. Now we know if you ask an Afrikaans-speaking person to name words beginning with an F, there are actually very few letters in the dictionary beginning with the letter F. So it's been sort of common practice to substitute a V. But somebody actually took the time and effort to go and do a study and see, can you compare it? And she went through all the words in the dictionary of English and Afrikaans and Xhosa to see how many letters are, in each word, how many words are in each letter, and then looked at, what is comparable. And then she went about getting norms for those three groups of people. And that study is available if you want to, my website will point to it. You'll find it on the website. If you want to get hold of that study and actually read it and get hold of the norms. But the letters she uses, and I stand to be corrected, are I, B, and L instead of F, A, and S. But so it's I, B, and L for Xhosa-speaking people, but it's S, B, and L for English and Afrikaans-speaking people. Okay. And just a little note, remember that design fluency is a non-verbal analog to verbal fluency. Why I put that in is it's useful sometimes to test non-verbal fluency, like design fluency, to see is it a language problem this person has, or is it a general frontal lobe problem? Because both verbal fluency and design fluency are in the frontal lobe. They're functions of the frontal lobe. And then, of course, the Ray auditory verbal learning test is useful for verbal learning as well. Now, there was a lot said about language, and I'm sure you understand language is a very important part of what makes us human, and when people have difficulties with language, it can have very far-reaching effects. So you'll see there's quite a lot to learn about language. In fact, I think there's a whole chapter dedicated to it. Okay, so let's look at visuospatial abilities in the brain. And again, one normally associates visuospatial abilities with the right hemisphere. There are many different types of things that can go wrong with our visuospatial abilities, and a lot of these things are difficult to test in a assessment situation. So often you just need to speak to the people to try and get a sense for what are the visuospatial difficulties they're having. And the type of thing I often ask them is, do you sometimes get lost? Or sometimes it helps to speak to someone who knows the person well. Do you sometimes get lost? Do you have difficulty finding your way home? Do you get lost in a shopping center? Do you struggle to find your car? Now, again, a lot of us struggle with that anyway, but I'm talking about a pathological difficulty. And if they do, then you need to tease it out and try and figure out what is it that's actually going on with this person. So you get topographic agnosia, which is the failure to identify individual landmarks, such as buildings. So, example, you recognize a building that it is a school, but you do not recognize it as the school that your children attend. That's topographical agnosia. Topographic amnesia is an inability to remember topographic relations between landmarks. So you might recognize a school as the one where your children attend, but you don't know where it's located. You can't figure out where it is in relation to the other things. And just a reminder, topo or top in Greek means place. Okay, so when you see the top there, we're talking about in relation to place. Egocentric disorientation is the difficulty perceiving the relative location of objects with respect to yourself, how far things are from you as a person. And unilateral or bilateral injuries in the posterior parietal cortex is responsible for this type of egocentric disorientation. Then you get what you call a heading disorientation, where a person is unable to set a course to where they want to go, even though they are able to recognize landmarks. So they may describe themselves as having no sense of direction. So this is where they're standing in a shopping center and they recognize the CNA and they recognize the Mug and Bean, but they don't know how to get to where they need to go. And injury in the right posterior cingulate cortex is responsible for that. So right hemisphere, posterior towards the back, cingulate cortex, remember where the cingulate cortex is? If you think of where the corpus callosum is, the gyrus just above the corpus callosum is called the cingulate gyrus. So we're talking about on the right-hand side at the back of the cingulate gyrus. Okay. Then you get landmark agnosia. It's where the person is unable to use prominent environmental features for the purpose of orientation. And when the person has this, they typically have lesions bilaterally or on the right side of the medial aspect of the occipital lobe, affecting the lingual and fusiform gyri and the parahippocampal gyrus. Now, it sounds like a whole lot of very big words, but just so that you can see, okay, this is this picture over here. That's the medial aspect of the brain. So the brain has been sliced in half. You're looking at it, the middle part, okay? This picture over here, here's the front. Okay, let me just quickly say, with this picture here, just to orientate you, this is the front of the brain, the anterior, that's the posterior. These two pictures, unfortunately, are swung around. If I could find different pictures that are in the same orientation as that one, I would. So in this picture, you've got the frontal area there and the occipital area there. Here is the fusiform gyrus, that yellow part over there. And there is the lingual gyrus. Okay, so you have damage in those areas if someone has landmark agnosia. So anterograde disorientation is where a person can navigate in formerly familiar environments, but they have difficulty learning to navigate in new environments. So you might have a person, for example, who has moved house. They could find their way around their old house perfectly well, but now they're in the new house, they can't. Or they used to shop their shopping center, and they happily go shopping and do their groceries, but the moment they go to a new shopping center or that shopping center has been renovated, significantly they struggle to find their way. And damage in the parahippocampal gyrus, or the inferior ventral cortex on the right, is responsible for that. So let's just think, parahippocampal gyrus, you know where the hippocampus is. It's the part that's responsible for memory. The parahippocampal gyrus is gyrus just below it, kind of hugging it, and that is found in the inferior, the bottom ventral cortex on the right-hand side. Okay. Just interestingly, you will probably read this in Kolben-Wishaw as well, where if you think of the hippocampus, the posterior part of the hippocampus is bulkier in London taxi drivers than in your normal person, because, and there's just an experiment done on the London taxi drivers, because they need to visually understand where they need to take their people to and where the roads relate to each other. So it is actually bigger upon dissection, the posterior area of the hippocampus, than your normal person. Now we have dorsal and ventral streams, visual ventral streams. Now you'll read about this in Kolben-Wishaw, but just to summarize it, visual information first goes to the occipital lobe. We know that, most visual information. It then gets processed further, so it goes to association areas. There are two different routes where it can go. It can either come down here, the ventral visual stream, where, look where it comes to, the inferior temporal lobe. Now we know just a little bit deeper in the inferior temporal lobe is the hippocampus, which is responsible for memory and knowing what things are, okay, because of the memory. So this ventral visual stream has to do with naming things, knowing what it is that you look at. It's drawing on memory of names, memory of objects, what those objects are for, okay. This dorsal stream, remember dorsal means top, ventral means bottom. This dorsal stream goes towards the parietal lobe. The parietal lobe, we know, is involved with spatial aspects. So it is the part of knowing where is it? Where is this thing in relation to other things? That's the dorsal visual stream. Now, both streams send projections to the frontal cortex to guide the movements of looking, reaching, and locomotion. So if you're looking for something, you're reaching for something, the frontal lobes are involved there. So from there, it goes to the frontal lobes. From there, it goes onto the frontal lobes. Okay. Now, you get different types of spatial behavior. You get route following, which is following a road or path, moving towards a landmark or reaching for an object. You're going towards something. Okay. Piloting is to take a course that is not directly marked by cue or route. You just know you've got to go more or less in that direction and off you go. Dead reckoning, you'll see there's quite a lot about this in Kolb and Wishaw. It's really using cues, such as what you see and so on, to help you go exactly to where you need to go. Now, there are interesting differences in spatial abilities. And I think we all know that adult males tend to perform better than adult females on certain spatial tests. Okay. But there's an interesting exception with left-handed people. And there was a very interesting experiment done with left-handed people, and they took left-handed people, compared them with right-handed people, but they looked at some people who are high reasoning, what they call high reasoning. They did very well in reasoning tests. Those are low reasoning. And your high reasoning left-handed male had lower spatial scores than the right-handed control groups, interestingly. And high reasoning left-handed females had higher spatial scores than right-handed control groups. But among low reasoning groups, the opposite was found. So obviously it's a lot more complex than we realize, and still a lot of information we need to get about this. And the last section I want to talk about today, we've now dealt with the visuospatial abilities, with language abilities. Now let's look at the brain's social and emotional functioning. There's a lot of very interesting information about our social and emotional functioning. Facial expressions are not always symmetrical. Emotional facial expressions tend to be on the left side of the face, showing a right hemisphere specialization in producing emotion. So, for example, a lopsided smile. If somebody's likely to have a lopsided smile, more likely to be on the left-hand side. So the left side of our faces tend to show emotion more than the right side of our faces. And I'm sure you already know the right hemisphere is more perceptive of faces. There's a very certain area in the frontal lobe, in the sort of inferior areas of the frontal lobe that is dedicated to recognizing faces and facial expressions. And this may be also just a good place to, because I don't know if you'll read about this in Kolb or Wishaw, but have you ever noticed that if you look at a photograph of yourself, there's something not quite right? You don't look the way, you almost don't really recognize yourself. There's just something wrong with the picture. And the reason for that is we're used to seeing ourselves in a mirror. And the mirror is the opposite to a photograph. So when we look at a person facing us, we are tending to focus on the right side of their face. Okay? Our right hemispheres are more the emotional side. So we tend to focus on what's going on in our left visual field, which is the right side of their face. Okay? So we are more tuned into that. So when and do this experiment with yourself. Notice for yourself when you're talking to somebody, do you tend to look more into the left eye or into the right eye, or right in the middle? You're probably more likely to look into their right eye. Okay. Now, when we look at ourselves in the mirror, we're looking on that side, our left visual field, which in the mirror is the left side of our faces. But when we look at a photograph, we're focusing more on the right side of our faces. And we know that our faces are not perfectly symmetrical, so we look a little bit different. We look a little bit odd, and that's the reason for it. Does it ring a bell with anybody? Can you relate to that? Okay. Now, the right hemisphere there's a right hemisphere specialization for correctly identifying facial expressions. Visual stimuli presented to the right hemisphere were judged more unpleasant and produced greater autonomic nervous system activation than the same films presented to the left hemisphere of other subjects. I don't know if you've come across this yet, but the right hemisphere tends to be a little bit more negative in its approach, a little bit more morbid. The left hemisphere tends to be a little bit more upbeat and positive. So, for example, if you have a patient who has had a stroke that has obliterated most of the left hemisphere, and they're using most of the right hemisphere, they're going to be a little bit more depressed, a little bit more morbid. Okay, and the opposite is true for if somebody has had massive damage to the right hemisphere, they're going to be a little bit more upbeat and positive. Okay, so it makes sense then that visual stimuli presented to the right hemisphere were judged to be more unpleasant and produced more autonomic nervous system activation because they just was perceived as more negative. Okay. Then also interestingly, there's a left ear superiority that has been shown for emotion-laden sounds such as laughing or crying. Because here the left ear projects to the right ear is more emotional, so there's a left ear superiority for emotional-laden sounds like laughing and crying, your emotional sound. Okay. Now, the limbic system there isn't just one area in the brain that's called the limbic system. It's made up of a number of structures. The thalamus, the hypothalamus, the prefrontal cortex, the olfactory bulb and olfactory tract, the amygdala, and the hippocampus. Now, I just want to say a note again about pictures of the amygdala. You will look at different pictures and people have drawn the amygdala in different places. It's always near to the hippocampus. Sometimes it will be right next to the hippocampus. Sometimes it will be enveloping the hippocampus. Sometimes it's on top of it. Sometimes below it. Apparently, it's very difficult to draw the amygdala. It's not an easy structure to draw. So different people interpret it in different ways. In this case, they've got the amygdala there, almost as part of the hippocampus. Okay, but it makes up part of the limbic system. And you will read that there are 3 main subdivisions of the amygdala. Now, when you think of amygdala, you must think of emotion. It is the fear center of our brains. You get the corticomedial, the basolateral, and the central part of the amygdala. And many cells in the amygdala are multimodal. Some respond to visual, auditory, somatic, gustatory, and olfactory stimuli. Now, some brain cells are unimodal. They only respond to, for example, let's say auditory, or only to visual. And you get some areas that are polymodal that will, for example, be visual and auditory, and maybe something else. But the amygdala responds to visual and auditory and somatic and gustatory and olfactory stimuli. It's an amazing little part of our brain. Now, we also know that the orbitofrontal cortex, that is the area of the cortex that is just above the orbits, just above the eyes. So it is if you take the brain and you turn it upside down, it is the part of the frontal lobe that you see there. Okay. Now, damage there that was found in monkeys led to reduced social interaction, loss of social dominance, inappropriate social interaction, altered social preference, reduced affect, and reduced vocalization. But we know that in humans as well, this is typical of damage in the orbitofrontal regions. Now, persons with right frontal injuries respond less to humor. They tend to have diminished smiling and laughter, and they fail to get the punchline of jokes. Persons with lesions in the right temporal or right frontal areas have difficulty recognizing facial expressions. Now, circuits of the amygdala mediate for fear conditioning. Remember, the amygdala has to do with fear. Okay. The amygdala has connections with the autonomic nervous system as well as the hypothalamus that controls hormones. So when a person is fearful, the amygdala is activated, your heart rate increases, you perspire more, and the bowel and bladder emptying processes begin. So that's your parasympathetic nervous system kicking in. So you're fearful of something, it's that typical fight and flight response. Your heart rate increases because you need to fight something or flee from it. You perspire more, and you have bladder and bowel changes. Where we typically see this is in panic disorder, stress responses, generalized anxiety disorder. Okay, here's a note on autism spectrum disorder. You can see from all the question marks here that there's a lot of uncertainty still exactly about autism. I think it's one of those fields where there's a lot of research going into it, but there are not a lot of answers yet. But there's possibly a cerebellar abnormality in people with autism. And this might explain the desire for sameness and avoidance of novelty, because the cerebellum controls conditioned responses. It might be that the children with autism can't habituate. So the normal brain, if we are placed in an area where there's a lot of noise, eventually we habituate and we ignore the noise and we don't really notice it anymore so that we can focus on what we're doing. You find people who live near to train stations and so on, eventually they don't really hear the trains anymore because of habituation. But it seems that children with autism don't habituate, so the noise remains noisy. It also seems that one of the reasons or one of the associations with autism is that pruning doesn't take place as it should. You all know that when children are born and so on, as we develop, there are a lot of connections that are made. And pruning of those connections are very important. And it seems as if with autistic children, that pruning doesn't take place as it should. Also, there are areas in the caudal part of the pons, that's the back part of the pons, that is small in autistic children or autistic subjects. And some nuclei in that area that control facial muscle movements are missing. Okay, so that also perhaps explains why, they might have like a flattened affect. And then we also know that some children have a savant syndrome where they are brilliant in something, but it's because of other things that are not functioning. So our brains are balanced in a way. There are certain things that are inhibited, and if those inhibitions don't work, then other things come out. So you'll sometimes find, for example, someone with a stroke. They were never artistic or never musical, and they have a stroke, and it kills off, in a sense, a part that was always inhibiting this other part. And now that that's gone, suddenly they are much more musical and much more artistic. And it seems that this might have something similar to do with autism, where there's this brilliance in, for example, mathematics or in music or something that wouldn't be there if the brain was normal. Now, just a few interesting things about schizophrenia. Schizophrenic brains weigh less than normal brains, and their ventricles are enlarged. And there's a reduction of the number of neurons in the prefrontal cortex with schizophrenic patients. There's also a thinner parahippocampal gyrus or gyri on both sides. Schizophrenia is another area where there's a lot of research going into it, but there's still a lot of unanswered questions about it. Bipolar disorder. There seems to be a decrease in grey matter in the temporal lobe and cerebellum relative to control groups in patients with bipolar disorder. And bipolar may have a progressive neurodegenerative aspect. As the research is being done, so this is being found that there might be a degeneration of the brain cells in bipolar patients. Now, as I said, I'm now really just fleetingly mentioned schizophrenia and bipolar and so on, and it's because it's a very important part of what we do. Not always so much as neuropsychologists, more sort of your clinical psychology and so on. You deal a lot with these patients. But I think there's a move towards trying to understand these clinical patients from a neuropsychological point of view, trying to really understand what is it that makes their brain different to somebody else's brain, and does it change over time? And of course, if we can understand it better, then we might know what to do about it and how to help them. Okay. Now, just a few words on plasticity and brain functioning. So there's a difference between compensation and recovery. We must be careful if somebody's had a stroke or a brain injury or something, we shouldn't use the word recovery. Recovery implies getting back to the way they were. But remember that brain cells cannot be revived or renewed. Okay? Cerebral plasticity is the transfer of function to other brain areas, so sometimes that is what helps a person get some of their functioning back. Sometimes there's a growth of dendritic branches and connections, helps them get some functioning back. Sometimes there's just spontaneous, what looks like recovery after TBI and stroke, because there was brain swelling and the brain swelling is reduced, making the brain more able to function. And then also there are certain ways of helping people regain lost function, not lost brain cells, but lost function, sometimes through the use of tools like walkers or cell phones to remind them of appointments and so on. Sometimes people just need to change their physical approach to things, like move their head to see better. Social support has been shown to be of tremendous help in helping a person function better after brain injury, and emotional support as well. And we know that there's a lot of research going into stem cells to see, because we know stem cells are little cells that can develop into other brain cells, into any other cells really. So there's a lot of research going into that, see if we can use that to increase brain functioning. And just regarding plasticity in the brain, I don't know if you already know this, I'm sure you do, but motor training can change the size of the components of motor maps in the brain. That area of the brain changes its size. You can see it you probably won't see it on a brain scan, but if upon autopsy you'd be able to see it. So a violinist who uses her left fingers a lot, on the right motor area where the brain function is, it will be bulked out. There will be more neurons, bigger neurons, more connections in that area because of the left hand that is used so much. Compared to the right hand, because on the right hand she's really just using the bow for the strings. I just want to mention this very quickly. There's an experiment where people wore prisms over their eyes, and it made the whole world look upside down. And they wore it continuously. And after, I think it was a few days, their world righted itself. But once they took those prism glasses off, their world was upside down again, and after a few days it righted itself. So it's how the brain adjusts to what it's exposed to. Also, just other examples of plasticity, early blindness early in one's life, results in the expansion of the auditory responsive areas in the parietal and occipital lobes. So because the occipital lobes can't be used for visual information so much because the person is blind, it gets used by the brain more for auditory process. Now, you've probably often heard this. People who are blind have amazing senses of hearing, and this is the reason for it. The brain actually uses those brain areas for other functions then. Now, this is also very interesting. Musicians, now you can imagine musicians, like pianists, okay? Those motor areas would really be bulking out where the hands are concerned. But you get a thing called hand dystonia. What happens, because each finger has its own brain area, okay, but now, so it's mapped out on the brain. But as each area expands, because of the practice, the areas between the brain areas become smaller and smaller and smaller. And with some musicians, there's eventually an overlap. And what happens is that their fingers get fused. They actually can't move their fingers apart anymore, because on the brain mapping, those areas have grown so close together that the brain sees it as one. So now people, this is just odd little bits of research and so on that's been done. People who've had their hands amputated, the brain area of their hand sometimes gets mapped onto their face. So that if you touch their face, they feel like that hand that's been amputated, they feel like that hand is being touched. Okay. And we know that people with phantom limbs who've lost limbs, the brain area for that limb is still perfectly intact. So that's why you might have lost a lower arm, but it can still itch, it can still be painful, not because there's actually anything physically here, but because that area in the brain is still there for that limb. And again, there's been some very interesting research done, because some people have pain in their phantom limbs. And there's been very interesting research done with a mirror box, where, let's say I don't have a left arm, but I stand with a mirror, with my hand behind a mirror, and I stand with my other hand like this, so it looks like I have another arm. And then somebody scratches, let's say it's an itch, somebody scratches this arm, and it actually relieves the itch in the brain for that arm. And it's also by the same author, Ramachandran, who's done these experiments. He has helped so many people who had apparently, what he says, people who've been in terrible accidents where their arm got twisted and so on before it was amputated. There was a lot of pain, and that pain is still associated there. So by using the mirror box, he straightens out this arm, and they feel like that arm is being straightened out, and the pain goes away because the perception of the brain is corrected, even though nothing is really happening physically to the arm. And this is my last comment on brain plasticity. You obviously you can't always assume that people's brain plasticity is taken, you can't take it for granted. It depends on area, it depends on the age of the person, whether the damage took place in utero, in childhood, in adulthood. And remember, there's also that up until the age of 2, if you have a brain injury in that time, it will probably be devastating, depending on the extent of it and where it is. Between the age of 2 and 5, there's almost a bit of just a time that if you have brain injury in that time, it is not as severe, because it is a time of brain development where it can easily compensate and grow new neurons and things to make up for that damage. From the age of 5 onwards, again, it has a more devastating effect. Now, this is your reading for the coming month. It may look like quite a short list, but it's actually quite a lot of reading. I've highlighted in blue the full chapters. So there are 5 different full chapters that I want you to read, and hopefully these slides will, you've now had an introduction to it. Hopefully the slides will just help you grasp the most important concepts and read through the rest.